Good evening, everybody, and welcome to our latest session of a Facebook Live. This evening's session is called Challenges of Managing Surgical Wounds Post-Discharge. My name is Alec O'Dare. I'm the Managing Director for Wound Care People. This evening's session is with Leanne Atkin, who's a Vascular Nurse Consultant, and Heather Hodgson, who's Lead Nurse Tissue Viability. Heather, Leanne, are you there?
Hi.
Yeah, you both well?
Yeah. Very well, thank you.
Brilliant. Brilliant. So for all of you watching at home, please do send in as many questions as you can, as per usual, via the chat screen. You'll notice, again, we say this every time, but we're all broadcasting from our homes. So if there's any technical difficulties, then just do bear with us. We will come straight back. Just a special mention tonight, sometimes in the chat, just lately, because there's so many people watching these events, we sometimes get a little bit of spam. So if anybody puts any links in there and it's not from us, please don't click on those. We are deleting them, so you shouldn't even notice them. But I thought I'd point that out just in case you do notice anything this evening. Without further ado, I'm going to hand over to Leanne and Heather. Your certificates will be available at the end. I'll be back after the presentation for a live Q&A. Enjoy the presentation. Thank you.
Hi. Welcome to this session, and I'm so pleased to be here tonight, and thanks to Essity for arranging this. So this evening's session is all about surgical site infections and surgical site wounds. So just to briefly review the learning objectives from tonight, what we're going to do is we're going to actually look at post-surgical wound healing and discuss some of the causes of the SSIs, talk about how important dressing management is, what is the available clinical guidance out there, and what's the difference between a surgical site infection and wound dehiscence, and how's best to manage this for your patient. Finally, we're going to talk about actually some of the patient impact. What does it mean to a patient if they experience a surgical site infection? And then I'm going to hand over to Heather, who's going to really bring it home about the individual impact, talk about her algorithm that they have developed up in Scotland and that they're using to reduce surgical site infection. And throughout all of this, we're going to be weaving in the importance of antimicrobial stewardship in terms of reducing the number of antibiotics that's used within the healthcare system. So let's start with where we should begin, and let's talk about the actual definition of what is a surgical site infection. Well, this is a common occurrence. It's very often post-surgery, and actually it says a surgical site infection often develops only after 1 week of surgery. But remember that an SSI can be classed as anything up to 30 days after surgery, or in fact up to 1 year if that surgery involved implants such as vascular grafts or metalwork. So a surgical site infection is an infective process present at the site of surgery, and with it comes some clinical signs and symptoms of infection. The classic ones are heat, redness and swelling from around the incision and around that wound. Often patients have an elevated body temperatures and sometimes elevated inflammatory markers and elevated white cell counts. You can get a purulent exudate, which is basically an exudate that has a tinge of pus about it from the wound or even from the wound drain. And as we said, it normally occurs within 1 week of surgery, but you have to be vigilant about this up to 30 days of surgery, and including up to a year for any implant surgery. So surgical wound prevalence in its totality is increasing. Originally, Julian Guest wrote a paper that looked at the prevalence of surgical site infection, which included data from 2012 and 2013. At the time, when he looked at the whole of the burden of wounds, surgical wounds accounted for 11% of the whole of that burden. But actually, his most recent paper shows that this burden is increasing. Looking at the data from 2017 and 2018, it's actually risen. And now we're looking at 14% of all wounds out there are a surgical wound in origin. The NHS spends billions of pounds on the management of wounds and the management of those patients. And the most recent data shows that we're spending £8.3 billion on the management of wounds each and every year. And in 2017, 2018, the NHS treated 3.8 million people with a wound. And around 500,000 of those were actually a surgical wound. And there is some terrible statistics that fall out of these 500,000 patients that's having a surgical wound. That of those, 35% of them had a recorded infection, a significant amount of those patients. And actually healing with those surgical wounds is not, as we all expect, relatively quick and relatively simple. The data showed that actually 15% of surgical wounds failed to heal after 12 months of treatment, which is a substantial number of our patients that are failing to heal. And along with this comes some worrying public health statistics, really, that 43% of surgical wounds were prescribed antibiotics. We had an increased burden with 88% attending A&E, a further 8% requiring hospitalisation but no surgery, and 6% required hospital admission with redo surgery. And Guest et al. Said that the average cost of managing a patient with a surgical wound was over £1,000 a patient. Who would have thought a simple surgical wound could be such a burden to the NHS, to the patient, in terms of cost and quality of life? So when we think about surgical wounds, I think it's really important that we all understand what we're talking about. And to do that, I'd like you to think about your underlying anatomy knowledge. So if you think about the skin, every single day, many of your interventions include the skin. We're checking its integrity, we're injecting it, we're helping it to heal. But if I showed you this diagram of the skin, would you be able to label this successfully? Would you be able to recognise each of those structures? Would you be able to recognise the depth of tissue? And I think it's really important that we recap this level of information so you all have a complete understanding. I think that this could be your homework tonight. You could print out this slide and try your best to label all of that diagram. So we aren't that evil. You can see that we've done this for you. And what's really important in this session is that we understand the depth of the tissue involved. So if you can see the information on the left-hand side, we can see the level of the epidermis, we can see the dermal layer, and we can see the subcutaneous tissue. And it's really important that we understand that when thinking about the classification of surgical site infections. So many of you will be relatively good at managing wounds. I myself am a vascular nurse and I deal with lots of chronic wounds. And with any chronic wounds, such as a venous leg ulcer, we're healing those by secondary intention. We're trying to debride them. We're trying to build up that granulation tissue. And we're trying to actually bring those structures back together and form an epithelial layer. But surgical site wounds heal in a very different way. You're actually arranging those tissue planes on top of each other where they should be, aligning them in surgery. So trying to heal the wounds by primary intention, really thinking about getting that subcutaneous layer perfectly aligned, the dermal layer attached to each other to help that regrowth and that regeneration of those wounds. Now, as much as chronic wounds such as leg ulcers and surgical wounds healing different ways by primary intention or secondary intention, each wound actually goes through the same stages of wound healing no matter what. Remember that the first stage of wound healing is hemostasis, stopping that blood loss. It goes on then to that inflammatory stage where we have the bedding down of the right amount of cytokines, white blood cells, providing that matrix, that foundation of those brilliant activators to get that wound to heal. Following that, we move on to the proliferation stage where we're trying actually to bring about the integrity of that tissue again. We're trying to build up the vascularity to ensure that we have good perfusion of that area. We're trying to build up the nerve supply again, so therefore we get that response of the skin that we need as a protective mechanism. And finally, we're trying to build that epithelial layer so the skin can do its job, be a protective barrier for us. But remember that wound healing doesn't finish there, and this is extremely important when you think about surgical wounds. You've got to remember that even when a wound appears to be integral, in terms of full of epithelial tissue, or you've got a incisional wound that appears to be adhered, that up to 2 years after that, there is maturation, remodeling underneath that tissue. And this is really important with surgical wounds, to bring back that full integrity of that strength of that skin. And if any of you's had a wound out there, you'll know that your wound looks relatively good, but around it you can get an area of numbness. And that's because actually the nerve supply is the last thing that regenerates. But eventually it should come back to a similar pattern to what it was before. So wound healing is complex, and we have to imagine what the pitfalls could be along this line. And just to recap again, in terms of surgical site infection, we classify these in terms of 3 different types. We talk about a superficial surgical site infection that only involves the subcutaneous tissue. We talk about a deep incisional infection, which involves the deep tissue going down to often to the fascia and to the muscle layer. And then we talk about organ space surgical site infections, when you have exposure of organs or vessels. So it's really important that we recognise some of the factors and some of the causes of what contributes to a surgical site infection, because there are many of them. There are many intrinsic factors, the patient's own factors, in terms of, are they a diabetic? What is their blood supply? What is their own oxygenation levels? There are very important extrinsic factors that are known to play a difference. What type of skin prep's used in theatre? How warm the environment is within theatre? How good is that aseptic control? But often there can be breaches within some of these intrinsic or extrinsic factors, and therefore we have an increased risk of surgical site infection. And when we look at the actual organisms that cause surgical site infection, the most common is Staph aureus. We can get some bacilli and some staphylococcus, some anaerobes and some group B strep, but the major one of most hospital-acquired infections is the wonderful Staph aureus. So surgical sites can become infected, and when they do come infected, you can get that inflammation around, but you can also start to get that breakdown of that surgical wound, where you get dehiscence or disruption of that scar tissue. But what is really important to remember is wound dehiscence can occur for many reasons, one of those being surgical infection, but it doesn't mean that every time you have a dehiscence of a wound, it is because of a surgical infection. In fact, it can be because of surgical error. Those tissue planes haven't been put back the way that they should have done. It can be because we haven't actually tethered the tensile strength of the muscle layer where we needed to. It can be because the wound has become ischemic. Either the limb has become ischemic or that local area of tissue surrounding the wound has become hypoxic and ischemic. There can be trauma. Evidence of too much stress falling on a wound can result in wound dehiscence. There can be mechanical stress or inter-abdominal or compartment pressure, especially thinking of abdominal wounds or wounds over large muscles such as over the calf. If that muscle starts to swell and expand, that can increase the internal pressure, and that will cause the wound to break down. You can have collections of blood and lymph fluid, and we're going to touch on that in a little bit later. But you can have wound dehiscence simply due to pre-existing chronic disease, especially things like peripheral arterial disease. So it's really important to think that, yes, a surgical site infection can cause wound dehiscence, but wound dehiscence isn't always caused by surgical site infection. So what we're trying to achieve in terms of surgical wounds? Well, we're trying to achieve good skin closure. Skin closure that's going to be cosmetically good, but also extremely integral. In other words, we are going to provide that skin barrier once again as soon as a patient comes out of theatre. And there are many ways that skin closure can be achieved. We can use clips, We can use sutures, either subcutaneous sutures or traditional sutures, and more increasingly, we're using tissue glues. But the choice of how to close the wound is really important. It's really important, and there are a number of considerations that have to be taken into account. One of the main considerations is actually the anatomical location of the wound, because it depends really on the thickness of the skin, the degree of tension, and the cosmetic result that you're requiring. So let's just think about that for a moment. If you're having carotid surgery on your neck, actually the thickness of the skin is extremely thin. The degree of tension on that area is very low, and the desired cosmetic result is extremely important because it's in a visual area. So we often use things like subcutaneous sutures because they get a better cosmetic result, or even more tissue glues. But if you think of an abdominal wound where you're going through multiple layers of subcutaneous fat, of muscle, the degree of tension on that area every time the patient breathes or every time the patient coughs, it's a tremendous amount of pressure. So you would never use tissue glues on areas like that. Some surgeons more and more for that final epithelial layer closure, but we tend to find that we're still using some type of suturing technique. But really, who chooses the closure? Has the patient got a choice? Well, no, not really. How to close a wound really is the surgeon's choice. And there's very little that nurses can do or healthcare practitioners can do to try to influence that consultant on which closure method to choose. So closure is important, but really is it something that we can play a part in or make a difference to? I would argue possibly not. So actually the role of us as nurses or healthcare professionals come really in that management of that wound post-operatively. So let's talk about some of the common complications that can occur. Very common complications is the presence of a seroma or a hematoma. Basically an area of filling with fluid around that surgical wound. And they're basically called different things depending on actually what's contained within that swelling. So a seroma is a simple collection of fluid, often lymphatic fluid, which is quite fluctuant. You can feel the movement of fluid around that area. And you can see that you can get a degree of swelling, redness and tenderness. With seromas, because they are lymphatic mostly, we tend to sometimes drain these by simple aspiration, but mostly we just leave them alone over time that they absorb and do relatively well. However, you can get a similar presentation, but when you've got a hematoma, when you have a collection of blood underneath that suture line. This is more pronounced if the patient's on any anticoagulant therapy or any of the new DOACs or the traditional warfarins. The problem is once you get a collection of blood underneath there is an actual increased risk of infection because the blood itself takes a while to break down. And within that, it can actually cause localized ischemia slightly just above it from where that suture line is. So you can get the same presentation in terms of that swelling. It can be a little bit more painful, the seroma, with an increased amount of erythema or redness. You still get a fluctuation around, but it's a lot more firmer fluctuation rather than that feeling of the movement of the fluid. With hematomas, we tend to try to leave them, but if we're finding out that we have got an increased amount of exudate coming from the wound, or even the wound is start to stress and come open, quite often we have to evacuate a hematoma. This can be done simply locally within an outpatient's clinic, but sometimes patients do need recalling back to theatre. So seromas and hematomas are relatively common complications of surgical wounds. And unfortunately, if a hematoma is not managed correctly or a patient is exposed to some bacteria, either preoperatively, perioperative or post-operatively, then the patient can develop a superficial surgical site infection. So just to recap, this is a classic surgical site infection. This is a superficial surgical site infection as it only involves the subcutaneous tissues. and it has occurred within 30 days of surgery or of 1 year following implant surgery. Most superficial surgical site infections will settle down with a simple course of oral antibiotics. Most commonly used is flucloxacillin. And these will go on to have a reasonable cosmetic result. The difficulty is when the surgical site infection starts to go deeper and it starts to involve the fascia or the muscle layer. And as you can see from this stump amputation or forefoot amputation, that the surgical wounds have started to break down, and these go relatively deep down to those tissue planes that you can see. And once you get to this level, you really start to impact on a patient's potential for rehabilitation. And unfortunately, these types of deep surgical site infection do take a number of days, if not weeks, to heal. And the final classification is those organ space surgical site infection. So when you have an incision that's broken down and you can see a vessel or an organ below it, and below this surgical site infection is an exposed bowel. And we all know the risks of once you get going down to organ space. There is a huge risk of any abdominal incision actually resulting in a fistula. Just for 1 second, imagine yourself, you've come in just for a routine laparotomy and you end up with a wound like this, and the risk of developing a fistula where you have fecal matter pouring out of your wound. The impact of this is absolutely massive to that individual patient. So we really need to focus on what are those risk factors, what increases your risks of a surgical site infection. Yes, the patient. We have to optimise them wherever possible. Yes, the environment. We need to reduce the risk of surgical site infection by following appropriate guidelines in terms of temperatures, skin check and skin preps. We need to consider what type of closing device we are using, what type of suture, what type of technique, what skin prep. But most of those actually are related to a theatre environment or a surgeon's choice. But here's where the nurse plays a huge impact. Let's just think about the secondary dressing for a second. So, surgical site guidelines have been existing from NICE for some time now, and even the guidelines from 2017, the surgical site infection guidelines say cover all surgical incisions with an appropriate interactive dressing at the end of the operation. So the important things to consider there is that word interactive dressing. So if you look at a definition of what an interactive dressing is, they say it's a dressing using modern materials which are designed to promote the wound healing process through the creation and maintenance of a local, warm, moist environment underneath that chosen dressing, and one that can be kept in place for a period of time, but allows that continual assessment. So just bear that in mind of what that definition of an interactive dressing is, and the fact that surgical site NICE guidelines says that we should be using them. And it's not just NICE that's saying this. The National Wound Care Strategy has a surgical wound arm, and they are saying the same thing. The recommendations from them about surgical wound management is to cover surgical incisions with an appropriate interactive dressing. That word interactive again. And I urge you all to download the clinical recommendations from the surgical wound and the National Wound Care Strategy. The link will be going up for you. It provides a great resume of what we need to be doing in terms of that pre-operatively, perioperatively and post-operatively to try to reduce the risk of surgical site infection. But what interactive dressings do you use? Because 99% of patients come out of theatre with a dressing like this, a simple gauze and pad type dressing. Would any of you out there consider this to be an interactive dressing? I certainly wouldn't. It's simply a bit of gauze with a pad. So why do we interpret the NICE guidelines in such a way? Is there an impact that we could have in terms of ensuring that that appropriate interactive dressing is used for patients post-operatively? So As you're all aware, NICE is the National Institute of Health and Clinical Excellence, and they are an independent organisation, and they provide real rationalisation to the National Health Service of how we can improve health and social care. And just to reiterate that NICE is an independent body, they've got a huge transparent process with quite a bit of scientific rigour, and they make recommendations based on health and clinical and cost outcomes. They have produced a recent medical technology guidance in relation to the Leukomed Sorbact dressing and the use of this in preventing surgical site infection. They've done this because NICE likes to actually look at new and existing medicines and devices and really question, is that value for money for the NHS to be using? And they base their recommendations on that clinical evidence and also but that economic evidence. Does it represent good value for money? And I urge you all to read the most recent NICE guidelines in relation to Sorbact, because the NICE technology guidelines simply says that Leukomed Sorbact should be considered as an option for people with wounds expected to have low to moderate exudate after caesarean sections and vascular surgery. Their recommendations is very clear that that's what we should be doing based on best health economic data. So why has NICE said that? Well, they've said that because of the impact that can happen when things go wrong with C-sections and vascular surgery. So I just want to spend my last few minutes talking about the true consequence of surgical site infections. Imagine you're a patient who has significant arterial disease and you've been told that your artery is blocked and you need a bypass operation. You undertake that bypass operation and then this happens. The wound starts to break down, the graft material starts to pop out of the side of your body. The wound breaks down so much that piece of plastic pipe that surgeon's just put in is exposed, and you're told that all of your arterial blood supply is now running through a piece of plastic pipe that's just at the base of your wound. And the consequence of this is that once we have exposed and infected graft material, we have no option but to remove this surgically. So what does that do to a patient if we are taking away that vital blood supply? The impact of this is absolutely massive. We're talking about loss of limb, in fact, potentially even loss of life, simply due to a surgical site infection. And imagine being that poor patient who's just had to lose their leg because of peripheral arterial disease. You've asked, how long would I be in a wheelchair for? How quick would I get a prosthetic and how quick would I be able to start walking again? And you get told only 3 to 4 months and you should be able to limb wear and you should be able to walk again. And then you develop a surgical site infection. Your stump wound starts to break down and there is no chance that while your stump is open, you will be allowed to use a prosthetic. So there you are, based in your wheelchair for how long? How quick before these wounds start to heal? We're not talking days or weeks, we're talking weeks or months. And within vascular patients, this could be precious time that they have. The impact of the patient for a surgical site infection is massive. Imagine you yourself facing theatre. Would you ever think about the potential of your wound going to break down and you're going to be left with an open, gaping wound? Patients report their initial shock of wound breakdown as alarm, shock, disbelief, how unexpected it was, how much they didn't even consider this in terms of their risk factors. It has a profound negative impact on a patient's quality of life. Patients talk about losing the ability to have physical and psychological functioning, the well-being issues that can happen, the feeling of frustration, powerlessness, guilt, how debilitating it is. And many patients have an unrealistic hope of healing time. They think if they develop a surgical site infection, it will be healed within a matter of days or a matter of weeks. And we know that once a surgical site infection develops, especially a deep surgical site infection or an organ spacing surgical site infection, It's going to take weeks or months, and they're on a significant journey to get back to well-being. So what can we do? Well, we need to focus on prevention. In surgical site infections, prevention is better than cure. We know how to do this. We need to follow nationally agreed guidance. We need to standardise those infection control precautions, thinking of that whole perioperative journey. We need to use surgical site care bundles as recommended by NICE, both in theatres and in wards. And we really need to be using those evidence-based surgical site infections, really focusing on that need for an interactive dressing. The use of Leukomed Sorbact in wounds with a low to moderate exuding potential following C-sections or vascular interventions. Never has prevention been more important. So I'm going to hand you over to Heather, who's just going to continue on this journey and really talk about her patients and what's happened to one of her specific patients, the profound impact this has, and what she's been doing locally to help solve this issue. Thank you. Heather, I think you're still on.
Yeah, that's us. Thank you, Leanne, and thank you, Essity, for inviting me to join you tonight. My name is Heather Hodgson, and I am the lead nurse for Tissue Viability in Glasgow, covering both acute and community. So, managing wound dehiscence. The World Union's definition of a wound dehiscence is the separation of the margins of a closed surgical incision that has been made in skin, with or without exposure or protrusion of underlying tissue, organs, or implants. In simple terms, it is the separation of the edges of a surgical wound. It may be just the surface layer or the whole wound. It may become a serious problem and typically occurs around day 7. Unfortunately, as Leanne said, some clinicians view surgical wound dehiscence as synonymous with infection. Surgical wound dehiscence can increase the risk of surgical site infection. Surgical wound dehiscence may not be caused by surgical site infection, and so it may not require treatment for infection. And not all infected or inflamed wounds dehisce. So to clarify, an infected surgical wound will not always go on to dehiscence. A dehisced wound is not necessarily infected, although the risk is increased. Some factors that increase the risk of surgical wound dehiscence include, as Leanne's already said, obesity or malnutrition. Excuse me. Excuse me. Smoking. Comorbidities like diabetes, malignancy, or vascular, respiratory, and cardiovascular disorders. Age, infection, surgeon experience or inexperience, emergency surgery or re-exploration of a wound, strain from coughing, vomiting, or sneezing, and post-op complications like seroma and hematoma. These can be categorised into 3 areas: technical issues, mechanical stress, and disrupted healing. Technical issues, the unravelling of suture knots. Mechanical stress, coughing can cause breakage of the sutures or rupture of the healing incision after suture or clip removal and reabsorption. And disrupted healing, due to the previously mentioned comorbidities or treatments that hamper healing or as a result of a surgical site infection. Nursing care is underpinned by evidence, which influences policy and guidelines. However, nothing resonates more than patient stories. And I would like to share the story of Alfie. Glasgow's maternity wound guidelines are dedicated to Alfie to ensure that best practice is delivered to every patient every time. And the timeline is as follows. Tissue Viability received a referral on Christmas Eve for a lady with a C-section dehiscence. She had been admitted a few days previously and was on IV antibiotics for that dehiscence. The wound assessment revealed a small 1 centimetre dehiscence, not much exudate. The TVN dressed the wound, discussed self-care management over the festive period, and Mum was coming back 3 days later on the 27th to the ward for review at the maternity unit. And the TVN ensured that the dressing was in stock on the ward. However, on the 27th, the TVN received a phone call from the ward looking for the dressing about 9:30 in the morning, and then another phone call at 3 o'clock in the afternoon, still looking for the dressing. Mum had been in the ward all day, and Alfie was not with his mum, he was with his grandmother. So a full day apart. The TVN obtained a dressing supply and went to the mum's house and dressed the wound at 7 o'clock in the evening when it was convenient for the mum. A few weeks later, the mum contacted the TVN to advise that Alfie was terminally ill and Alfie has since died. So we can learn a lot from reflecting on Alfie's story. Accurate wound assessment, appropriate treatment options, including antibiotics and dressings, appropriate admission. Should Alfie's mum been admitted? Should Alfie's mum be given IV antibiotics? Person-centred care. Was that the best thing for Alfie and his mum to be admitted to have IV antibiotics for their very small wound dehiscence? The TVN had already started developing wound guidance in partnership not only with midwives, but industry and women to ensure that this was clinically effective, evidence-based, addressing antimicrobial stewardship and person-centred. I dedicated these guidelines to Alfie to ensure that in future there was guidance for clinicians to help them prevent or manage dehiscence, to prevent or minimise the need for readmission. In partnership with industry, the team rolled out the guidance. And since rollout, the number of women being readmitted to hospital and requiring TVN intervention for either an issue with episiotomy wound or C-section wound has reduced by 100%. Yes, no readmissions that require TVN intervention. It is everyone's responsibility, both clinicians and the general public, to collaborate to reduce antimicrobial resistance and redress the balance presented with these startling facts from the World Health Organization. Antimicrobial resistance is one of the biggest threats to global health, affecting everyone. Misuse of antibiotics is one of the major causes, with diseases becoming harder to treat and increased mortality. We must educate colleagues and patients that antibiotics are not always the answer. Leanne alluded to the startling paper by Guest, published last year, where it was revealed that 43%, nearly half of surgical wounds, has had at least one course of antibiotic prescribed. It's almost a badge of honour when a patient is being treated by antibiotics. How often have you heard people say with pride, "I'm on antibiotics," or "I needed a stronger antibiotic"? The best practice statement published last year on antimicrobial stewardship strategies for wound management contains a wealth of information, well presented, really easy to read. It contains the 5 rights for antimicrobial treatment selection. It highlights the importance of undertaking and documenting a holistic assessment of the patient, the wound and the wound care environment in order to guide antimicrobial treatment. If a bacterial cause for a spreading or systemic infection is suspected, appropriate microbiological investigations should be started to identify the type of microorganism. With that said, we should not be routinely swabbing all wounds, only if there is suspicion of spreading or systemic infection. The use of antibiotics must comply with local antimicrobial stewardship policies. Within Glasgow's maternity guideline, there are products that offer an alternative approach to the management of increasing bacterial load in chronic wounds, such as dressings with a physical mode of action that are effective in wound bioburden management. I'm really fortunate to be part of a group set up in partnership with Essity, looking at the Scotland's antimicrobial stewardship arena. This group, in partnership with Essity, has brought together clinicians from all over Scotland from different disciplines: tissue viability, podiatry, vascular. It provides a relaxed, informal platform to share their antimicrobial stewardship experiences through audit, guidelines, education initiatives, and practical experiences. So in summary, I think we have explored today several issues relating to surgical site infection and surgical wound dehiscence and the relationship between both. We have shared some resources, guidelines, and given practical solutions for wound management. And I'd like now to hand over to Alex.
Thank you, Heather, and thank you, Leanne, for another great presentation. We've had, as always, many questions coming through. There's been lots of interest in the subject this evening. So we're going to get started. Before we do, just because I didn't mention this at the start, if I could just thank Essity for their support for this evening's event. I normally always remember to do that, but I got slightly sidetracked, so I do apologise. So thank you to Team Essity. The first question is for you, Leanne, and this is: what are your thoughts on swabbing? When should we swab?
Oh, what a question. Okay, so let's start off. Can we make sure that we're swabbing correctly, I think, is the start of all of this. So remember that we shouldn't be swabbing in that zigzag rolling fashion anymore, and we should be using the Leanne method of wound swabbing, so targeting an area and taking a good swab from that 1 centimetre area. So if you're not aware of those changes of guidelines, please review them. In terms of wound swabbing, I used to say, please don't swab a wound, but I think we've thrown the baby out with the bathwater a little bit here. We need to really think about the differences of what type of wounds that we are treating. So let's remember that all chronic wounds will have a degree of colonisation on them. You'll always find a positive wound swab somewhere of something. Surgical wounds are very different. If we do start to dehisce, I think it's really important that we consider the impact of bacteria on that wound. So I think for surgical site wounds that starts to dehisce, we should be using a wound swab more. And we should be doing that to target the sensitivity. Is it Staph aureus? Do we need fluclox, or have we got some other bacteria there, and therefore do we need to target that antibiotic? So rather than giving everybody that broad course of antibiotic for a long period of time, I think that we really need to be targeting that. And wound swabbing really checks that sensitivity and that specificity of that antibiotic itself. So I think lower your tolerance, if you like, with wound swabbing, especially for surgical wounds. For chronic wounds, if you can't think of any other reason of why that wound isn't healing, therefore they are showing signs of localized infection, consider taking a wound swab. And there's some great guideline that's been produced by the European colleagues in terms of humour, in terms of how to look at and how to recognise wound infection.
Yeah, cheers, Leanne. And with regard to both that document that you've just mentioned and others that have been mentioned throughout the presentation, we will be putting links onto the chat panel there, where you'll be able to access them and download them. The next question is for Heather. So this question is: what could we do as clinicians to help prevent wound breakdown?
Some wounds you might not be able to prevent that breakdown, but within the documents that we alluded to, there's lots of guidance, and you can start with looking at the patient themselves and looking at comorbidities and actually minimising the risks. You look at the environment to make sure that it is clean and tidy, and that you are reducing again the risk. You look at yourself as a clinician and your PPE and your hand washing and your jewellery wearing and your hair, etc. And you make sure that your patient is advised on hydration and diet and healthy lifestyle and good hygiene and following the guidance given for their wound. Going back to the C-section guidelines, we have introduced, and I'm sure that there's lots and lots of places throughout the country, they are putting in measures to prevent wound dehiscence immediately at closure. For example, the application of disposable negative pressure in the high risk areas, and recognising if they are going to be high risk and putting in place measures to reduce that risk.
Yeah, and I guess it comes down to, such a broad question, isn't it? Because I guess it comes down to just going right back to the basics of just assessment. You assess the wound and come up with a decent care pathway, and then everything we've talked about should prevent the wound from, good dressing choice, good management, and all the rest of it should prevent it from breaking down further.
Just to put in there, Alec, though, I think that what's really important is that we actually write these guidelines. That interactive need for that interactive wound dressing has been in that NICE guideline for many years now, but it's not actually put into practice. So I think one of the things that we really need to do is to ensure that clinical guidelines are using everyday practice, that patients are coming out with an interactive wound dressing. If you were about to go into theatre, would you want an interactive wound dressing, or would you want a gauze and pad as you came out of that theatre? We have to be looking at what NICE recommends. NICE is our clinical excellence. We really should be implementing that. And I think the one thing that we can do as a nursing fraternity to reduce surgical site infections is pay heedance to that ANTT. It's there for a reason. You don't need an aseptic technique with a chronic wound. You do with a surgical wound. We really need to be thinking about that management of that and how we are introducing potential bacteria into that wound.
Yeah, I agree with all of that. Leanne, this is for you. This is from Vicky. This is quite a specific question. It is it better to dress a hematoma or leave it open if intact?
Okay, if it's intact with no exudate coming from it at all and the skin is perfectly intact, you can leave it exposed, and it's a good way actually to get the patient to monitor it. As soon as you have any start of leakage, even if that's just serous fluid that's coming out of that wound, then you have an open aspect, and it's at that point we need a wound dressing on. Once again, if we haven't already got bacteria in there, it's about covering it to prevent bacteria being part of that. But hematomas are always devilment of things, if you like. Quite often, if you know that you've got a hematoma, watch that wound carefully, because if that wound starts to break down, they tend to break down quite nastily.
We've talked quite a lot about interactive dressings in this presentation, but I'm assuming that you wouldn't be looking for an interactive dressing if you were to cover that. You'd be looking for something just as a protective dressing. Is that?
Well, I really think, and it'd be interesting to know Heather's opinion of this, I really think that we should be using interactive dressings on everybody wherever we can. I really think that we shouldn't be using the gauze and pad. I don't think it is an appropriate dressing. We know moist wound healing environments work, so we have to provide dressings that actually facilitate that wound environment.
Excellent. Heather, anything you'd like to add to that?
Yeah, absolutely. And going back to the maternity guidelines, NICE guidelines have demonstrated, certainly with the negative pressure and high risk C-section wounds. But yes, it's we have to reduce the risk and promote wound healing wherever we can.
Yeah, good. The next question is very broad. I imagine the two of you are going to have quite a lot to say about it. So this is for the both of you. We'll start with you, Heather. But the question is, what else can we do to combat antimicrobial resistance?
Well, you should.
We've got about 10 minutes left, I think.
Okay.
So,
you should all get a copy of this. Can you?
Yeah, and so we can put a link to that onto the screen now. Actually, we're planning on doing that, so we'll definitely do that.
Yeah, and so that's it's really good reading. We should be brave, and we should challenge ritualistic swabbing. We should challenge ritualistic prescribing, and as Leanne says, it should be targeted. So only those that need swabbing should get swabbing, and only those that need antibiotics should get antibiotics. And I think there should be more of a public campaign as well, because the general public think that antibiotics will fix everything. And that's a major misconception we have to challenge. And as clinicians, we often perpetrate that. We think, oh, well, we better get them an antibiotics. If someone's not systemically unwell, you really should be thinking, is this the right thing to be doing? Even first of all, swabbing if they're not systemically unwell, and certainly not prescribing them antibiotics if they're systemically well.
Okay,
I think the overuse of antibiotics is multifactorial. I think a lot of it is embedded within culture. I do think the world can wake up to this, though. I think that we've all seen what it's like to treat a disease with no known therapeutics. Those first few months of COVID is what's going to happen if we carry on using antibiotics like we are doing. Once we get antibiotic resistance, everybody will have significant problems with people dying of superficial infections, of pneumonias. Think about how we use those antibiotics. But I think from a nursing point of view, we need to use what we can to prevent the need for antibiotics. So it's about looking at those guidelines. It's about using different technologies. The Leukomed-Sorb Act works in a very different way in terms of how it binds bacteria. That's a very effective way that doesn't require antimicrobial usage. I also think that we really need to think about where is our training from a nursing point of view, especially if you're a nurse prescriber out there. When was the last time you had antimicrobial stewardship education? GPs have to do it on a yearly basis. Now, I don't believe that we should be adding anything more to our mandatory training yellow page list that we have. But at the same time, I think that if you are a prescriber, you need to be aware of the risks. And as much as I think we are all aware of the prescribing risk for oral antibiotics, I'll hold my hand up. I'm a terrible user of steroid cream with antibiotics in it. And what does that do in terms of its antimicrobial risk? So I think it's just really waking up, questioning your own practice, and helping to change that widespread culture.
Are we potentially, though, going the other way and almost scaring clinicians into not using antibiotics or antimicrobials or antibiotics actually when really they should, because they just keep hearing the message that they shouldn't prescribe them? I ask because I recently visited the dentist. It's got nothing to do with wound care, but it's sort of linked to this. I needed a root canal. They gave me an appointment, which was for a week later. I told them I was in pain. I left with nothing. They told me to take some paracetamol. Terrible pain. Called them back up. 2 days later, they prescribed me some antibiotics, and within 24 hours, the pain was gone. And that was with, and the swelling and stuff. So it was clearly the antibiotics that worked. And I did wonder whether, is that healthcare professional just initially, 5 years ago, would I have got antibiotics immediately? And now everybody's being told to calm the usage down because of the risk of resistance.
Absolutely. 5 years ago, you would have got some penicillin of some description, but I would argue, how do you know it's the antibiotics? How do you not know your simple immune response that made that reaction to you? I do think, like I said, I think we've thrown the baby out with the bathwater a little bit, especially me in my own practice. I hardly ever use antibiotics apart from for diabetic foot infection or osteomyelitis, but for wound infection, hardly ever. And I've reined that back in a little bit, that if I'm finding a wound with local infection evidence, so a stalled wound healing, a static wound, increasing odour, a wound that's not actually moving towards healing, then actually I am taking a wound swab. And if I find something like a strep or a staph, I am providing targeted treatment.
Yeah, it's a really, really interesting subject. We've got a couple more questions. I'm keen that we get through these. So the next one is for you, Leanne, again. Any advice for what we can offer patients regarding surgical wounds and self-care?
Yeah, good advice, good information, and don't forget the power of an information leaflet. If ever you've been in hospital, you do read that leaflet. We think that nobody reads an information leaflet. They do. If you've ever been a patient, and I know I have, I had a detached retina, I read my patient information leaflet 3 or 4 times, thinking about, is this a normal process? Is this what's expected of me? So don't forget the power of the information. Self-care is important, but we do need to increase that. How does a patient report a surgical site infection once they're discharged? C-sections used to be kept in 5 or 6 days. I believe now they're doing a day case, aren't they, Heather? That, that we are moving things quicker and quicker out of hospital. So we have to, self-care is great, but we need to make sure that there are the appropriate escalation processes in place, that patient can ring that alarm bell and get back to us if needed, because SSIs are still underreported.
Yeah, and what about you, Heather? Anything you'd like to add to that?
Yeah, I think COVID forced our hand for self-care. And certainly, in my experience, patients will be able to deal with their own wounds on the whole and manage very, very well, and in some cases better, because they'll take the time and they'll inspect it. However, there are 1 or 2 that are either physically or emotionally unable to do so, and they may not have the social circumstances to allow them to do that as well. But the majority should be able to self-care and self-care well.
And I think when we're talking about self-care, we need to really ensure that this is self-supported management, that we are providing that support. We think that patients are resilient. Quite a few of my family, if they see any of my work pictures, they could fall over. We look at those and we think, oh, it's day-to-day running. It's quite normal for us. We really need to understand the patient's resilience and where they are. If you were a new mother with your baby in your arm and you looked down and you had exudate coming from your ugly cesarean section scar, I think I'd be wanting a healthcare professional to give me that reassurance of this is going to be okay. And I think that we can't factor in what else a nursing input has. We don't simply just change a dressing and run away. We do a lot of other holistic management of that patient, which is as vital as that dressing change.
Yeah. Final question. I think we've come to the end of the evening, and this is there any new guidance or guidelines on type of dressings for dehisced wounds? Either of you know of any?
So there's certainly, like Heather said, there's certainly a lot on prevention. There is some about topical negative pressure, disposable topical negative pressure for small wound dehiscence. There is certainly no large randomized control trials of how to manage a dehisced surgical wound, and I don't believe that there is any nice guidance at this moment in time, but it's certainly something that we need to develop more and more of.
Okay. Heather, are you aware of anything?
No, like Leanne, negative pressure that's got an irrigation system within it helps certainly promote the healing and increases the rate of healing by 43%. It's quicker when you've got an irrigation system going through there as well. But no, it's all about holistic assessment and what dressing is best for that person, making it person-centered. It's treating the whole of the person instead of the whole in the person.
Yeah, I love that. That's something that is I've heard a lot, and it's a great saying. Heather, Leanne, thank you very much for joining us this evening and presenting on such an interesting topic. For everybody at home, thank you for giving up your time. We recognise that today was, in most parts of the country, the hottest day of the year. So we thought that lots of you would have had last-minute emergency barbecues going on and sipping rosé in your garden. So thank you very much for joining us. Thank you very much to Essity, and thank you to my team as well, who've been working very hard to bring you this event. There should be some links on the screen now for where you can obtain or download the nice guidance that we've been talking about throughout. But you can also email concierge.service@essity.com if you've got any questions about the presentation, or if you want to get a copy of that nice guidance, they'll send you one. If you've missed any of this, the presentation will be available via our website from tomorrow, along with the slides, as well as available within the next half an hour, usually on the Facebook page. There should also now be a link on the chat screen there for you to download your certificates. Just leaves me to say thank you very much for joining us. If you do happen to be around tomorrow lunchtime at 1 o'clock, we'll be back with a virtual lunch meeting talking about some products then, so do come and join us. Thank you very much, everyone. Thank you, Essity. Have a good evening, and we look forward to welcoming you back at our next event. Goodbye.